Good morning. My name is Nonniekaye Shelburne. I'm a program officer with the National Cancer Institute in the Division of Cancer Control and Population Sciences. Thanks to the organizers for having me. I'm going to take a few minutes just to introduce you to NCI and our interest in the intersection of cancer and emergency medicine, talk about some of our initiatives, and then get a little bit into, again, reiterating things you need to consider whenever you're going for your first grant, whether it be a training grant or an R award. So NCI has been around since the early 1930s. It was a congressional act that put us on the map. One thing that's different about NCI from other institutes at NIH is that our director is presidentially appointed. Therefore, every time there's a change in the White House, there's a change in our director, you hear new priorities, but in essence, most of the time our priorities are pretty stable, which is that we fund cancer research. And we do this across the cancer continuum, looking at how cancer develops, but also how we screen for it, detect it, treat it, and care for our long-term cancer survivors. We have several networks across the United States, one being Comprehensive Cancer Center, some of which you may work in. We also have our clinical trial network, which focuses primarily on drug trials. We have a community oncology research program called NCORE, which also try to move all that research into the community, and they have a healthcare delivery research component, which really is an area that we're trying to engage in emergency medicine to say, how do we care for oncology patients in emergency medicine in these community sites? And then we also have training awards all the way from high school, undergraduate, graduate, and for our scientists looking for research funding. So again, we work across the cancer continuum in places we see intersections with emergency medicine and prevention. We're looking at substance abuse prevention programs in the ED, tobacco cessation, potentially HPV vaccinations. Unfortunately, patients do have detection and diagnosis in the ED. They come in with GI obstruction that turns out to be colorectal cancer. Our patients receiving active cancer treatment come in with many symptoms and toxicities from their cancer treatment that they are unable to manage at home or through their clinics. And then our survivors, we have patients 10 years out of treatment that are having cardiotoxicity, congestive heart failure at the age of 30 when you're not expecting it. So these survivors can look very different. So understanding their history of cancer is very important. And the picture on the left is our campus, which resides up in northern Rockville, Maryland, just north of the NIH main campus. So in 2015, Jeremy Brown in the Office of Emergency Care Research and I got together realizing that really there was a paucity of research in the intersection of cancer and emergency medicine. And so we decided NCI as a funding body and the OECR as a coordinating and facilitating office should get together and try to fill this gap. So first thing we did is in 2016, we pulled together a small group of oncologists and emergency medicine physicians to say, what's the low-hanging fruit? What do we need to be doing in this intersection, and where do we need to take this field? So we put out the first research agenda paper in the Annals of Emergency Medicine. Because it's such a new field, if you are looking for something new and exciting, and the world is your oyster, cancer and emergency medicine is a great place to start because we have very little that's going on. And we're looking for our investigator-initiated science in this area. So we have this website up, and it details our interest, but it is not limited to this, but really looking at observational or intervention studies, looking at cancer health-related outcomes, interested in the utilization of the ED by cancer patients, all the healthcare delivery system factors that drive that ED use. Once our patients are in the ED, how do we risk stratify? How do we risk predict based on their symptoms? What are the evidence-based strategies we're using? Because right now, in emergency medicine, we're using the evidence based on DVTs and any other patient population, but should we be treating them differently? So we need to look at all those evidence-based strategies and think about the cancer population as something special. And then how do we reduce ED visits when they're unnecessary? So when we looked at utilization at the time, Mueller et al. Was the only person that had really looked at utilization using the Nationwide Emergency Department survey and looked at pediatrics. And she found that about 300,000 visits per year were by cancer pediatric patients to the ED, representing about 0.2% of all pediatric ED visits. But almost half of those patients were being admitted straight from the ED. So my team, we decided to duplicate this in the adult literature or the adult population, and we found that it's 4.2 million adult ED visits are cancer-related, which is about 4.2% of all yearly visits, and about 60% of those patients are being admitted to the hospital. And when you compare that to the non-cancer population you see in the ED, it's a significant difference in why we're admitting patients. So this is a huge research gap. Why? Is it because we don't have the support in the ED, because we don't have the evidence to support whether you can triage them and send them home or whether you need to admit them? But we need, are these unnecessary visits? We need all this information to improve care. And then the patients are looking different as far as age. On the left, non-cancer visits compared to right, cancer visits. Less than 50% of non-cancer visits are under the age of 45. Over 90% of cancer visits are over the age of 45, with a large portion of being over 75. So geriatric oncology being represented. The pediatric and adults, when they come and you look at their cancer presentation, it's very representative of what we see as the primary tumors in those populations. So children, leukemia, CNS tumors, neuroblastoma; adults, the 4 major solid tumor types. When we're looking for reason for ED visit, our pediatric patients are coming in a lot with fever without neutropenia. Is that something that we could be preventing? Is that necessary? They're coming in with infection, headaches and seizures, primarily associated with acute lymphocytic leukemia and its treatment, and dehydration. And our adults are coming in with an infection, chest abdominal pain, cardiac, GI obstruction. Some of these may be age-related complications and comorbidities, some related to the cancer, some related to the treatment. So we need more investigation into these reasons for ED visit and how we're caring for the patients. So we decided we need a coordinated effort to be able to look at the intersection of cancer and emergency medicine, so we developed the Comprehensive Oncologic Emergencies Research Network, or CERN. This is an unfunded but NCI-supported network, more like a consortium, where Karita Grustin and Jeff Caterino are currently the co-chairs, and Jeremy Brown and I are NIH liaisons. And the goal is to provide a panel of experts that can come together and try to fill this research gap through doing multi-site studies, through supporting each other, providing scientific and advisory committees. So if you have an idea that you would like to float by them and try to perfect, they can assist you with that. Whenever it looks at data elements across cancer emergency medicine, this is kind of a new thing we're looking at. What are the right elements that should be collected across these studies? And so we have a committee specific to helping with that. And then if you have manuscripts or abstracts that need to be reviewed, we have some experts to support that. And of course, if you're using the network, they'll also support that and make sure that everything is being represented. CERN is open access, so you can go to this website and you can join, but we have representation across the United States and also in Barcelona. CERN just completed a prospective trial, a study of 18 sites looking at cancer patients who came to ED, observing them, getting survey data, getting medical record data, and doing 30-day follow-up to try to get the first prospective study on cancer utilization in the ED. And NCI is doing the analysis for that and supporting them with data cleaning, and so we have papers and abstracts coming out, some of them at this meeting, and also moving forward to hopefully get them to the oncology meetings as well. CERN is also working very closely with our Community Oncology Research Network. We actually have one funded investigator through that network already to be able to look at some of the utilization components within community oncology, and then we have 2 other networks that are very interested in understanding how we can move forward with studies in cancer and emergency medicine. So whether your idea came from me and with patients, or it came from a meeting like this, hopefully you heard cancer emergency medicine, thought, wow, that sounds interesting, or NHLBI's initiatives, you know, what do you do next? And Jane mentioned that really the first thing, and I completely agree, is you go to NIH Reporter, and the top one is the website for that, and you find out what's already been funded and who's funding it and who you can talk to get more information. Each institute also tends to have support in different ways to be able to search what each institute is funding, and so NCI has that, as well as each division. So my division of cancer control on the bottom also has a way you can search funded grants as well. NCI, like NHLBI, has a cancer training branch, and we do support fellowship awards, research career development awards, and training and education research awards within cancer. The branch manages all of those, and they reach out to program officials like myself whenever it falls within the area of expertise, and so they would contact us and work with them. But your first point of contact would be the training branch at NCI if you were interested in anything with cancer and emergency medicine. These are just some examples of some funding announcement that NCI has out, as well as other institutes. And as Jane mentioned, we all sign on to different institutes' announcements. So it doesn't just have to be one institute. And because emergency medicine crosses institutes, it's important to look at ones where we all jump on board. And many times that means there are options for co-funding. So you may have a very expensive grant, but may say NCI will cover 50%, NHL Big I 50% because it crosses both domains. That can actually be very helpful for you and be able to get funding because it takes the burden off one institute. So the first one, RO3s are your small grants, so these are $50,000 a year for 2 years, just to get some small, usually analysis done. R21s, your 2-year exploratory grants, so these are about $225,000 over 2 years. You don't have to have pilot data. It's something where you're really just exploring and trying to get the pilot data so you can move on to your RO1. And then your RO1 is your 3 to 5 year major grant. You want to consider whether or not you want to do an intervention or you don't want to do an intervention. So as starting this last January, NIH is looking at intervention grants very differently and trying to collect more information on human subjects. And so that means that funding announcements now say whether clinical trials are optional, not allowed, or required. So you want to make sure you're looking for the right funding announcement. And an intervention is any prospective assignment of patients to an intervention that is looking at how that's going to influence health outcomes. Just some other ideas like dissemination and implementation research. There's RFAs on that. And the bottom two are actually ones by other institutes that NCI signed on to. So substance abuse from NIDA, but we're interested in that, how that affects cancer patients and reducing substance abuse and the prevention of cancer. And then geriatric palliative care by the National Institute of Aging. NCI, again, interested in that geriatric cancer palliative care. So when you pull up a funding announcement, look at the top and see what institutes have applied to that. As Jane said, can't say it enough. Call a program official, call a program director, figure out who to call. Sometimes that's looking at a funding announcement and just saying, I think this fits in there, I'm not really sure. Can you tell me if this is correct? Or reaching out, if it's NCI, contact me. If you don't know, contact Jeremy Brown in the Office of Emergency Care Research. It's our job to triage your ideas and get them around. So please don't hesitate to contact a program official, or even a branch chief. And if you don't hear from them back within 2 or 3 days, contact someone else or send them another email. Don't stop there, because we want to keep you from the pitfalls that we see with our patients, or with our investigators, because we want to make sure that what you're proposing fits within the FOA that you're choosing, the study section you're choosing, and making sure that it's within the priorities of the institute you're choosing. One thing that is a misnomer, people believe that study sections are institute specific. Study sections are not, unless it's a special emphasis panel for a very specific funding announcement. They are NIH-wide. So I have a large portfolio and program looking at cardiotoxicity in cancer patients who've received treatment. So I have NCI grants that go to congestive heart failure study section. And so, again, they're not institute specific. So when you're looking at study sections, don't worry about whether you think it's specifically within an institute, but that it covers the domain and expertise that you're looking for. So things to avoid. You want to make sure that your scientific rationale makes sense, that there's not flaws in your methodology, that it's a very focused research plan. You need to have published, and as Jane said, you need experience in the work in which you're going to work with, and you need to make sure that the other investigators you're working with on your proposal can support that as well, through that expertise on your research team. You want to make sure that the budget and the time frame you're requesting match your science, because your reviewers will be looking for that, and you want to make sure that you're not asking for 5 years of funding on something that really is only going to take 3. And you might think, well, I want the 5 years of funding for the work I'm doing because it takes so much to put an application in. But you actually, if you put it in as a 3-year funding, you actually might get higher priority for funding with a worse score than someone who asked for 5 years because of looking at the budget. So there's ways to kind of play that game. I'll also put a plug in here that once you get funded, please put your name in for being on study review panels and study sections. We do not have enough emergency medicine reviewers on our study section, so when I have someone, an application comes in and I'm talking to the study review officer and trying to figure out who has the expertise, it's a small pool. So, and if you have other people at your institution that have been NIH funded, ask them, are you have you put your name in the pot to be on study sections? You'll find proposal writing without failure under fiction. So most first submissions don't get funded. Occasionally they do. And I've actually had early stage investigators, new investigators get funded, but it is the rarity. Don't be disappointed. Take the feedback from the reviewers. Usually that second, maybe you might need a third submission, is going to be even a better study. So in the end, you're going to end up with a great outcome. So again, make sure your hypothesis is very focused. Make sure that you're asking you have the right preliminary studies if you're going for an R01, that it's innovative and that your budget is reasonable. Every institute has different ways to learn about what they're doing. This is some examples for NCI. We have a blog, the NCI Cancer Currents. You can sign up to receive funding announcements. For NIH-wide, you can receive weekly email from NIH on their funding guide that talks about all the new funding announcements, requests for information that come out. So I encourage you to sign up for that. It's just a good way to get an idea of what all the institutes are doing. But remember, if you don't see a funding announcement on the idea that you have, don't stop there. Most of our applications are investigator initiated, and we appreciate that. And there's actually, it vacillates between whether NIH wants funding announcements or they push back on not having funding, broad funding announcements. So don't stop there. If you have any questions, happy to take them at the end of the program, but also if you want to email me or call me, let me know. I'm going to turn it over to Joe.